so here's a quick overview of my talks. We'll do an overview of local anesthetics. We'll go over some nerve block techniques. We're going to just briefly touch upon some local anesthetic toxicities, and we'll talk about nerve blocks as headache adjuncts. So this is your first PGY3 overnight jail shift, and you're feeling pretty confident. And this is your first patient. He comes in. He's a 35 male, referred from jail after he has a laceration to his brow after he fell from the bunk. What is your optimal anesthetic technique? So we'll come back to this. So this case is a good example of why regional anesthesia nerve blocks are important. Especially on the face, regional nerve blocks don't distort the tissue the way that the local infiltration does. And thus, it allows for better precision and consequently better cosmesis. You can also cover a larger area with a smaller volume of anesthetic, and thus you decrease the risk for toxicity. Studies have shown that regional blocks achieve better superior pain control, are better tolerated by patients, and also decrease the need for opiates. I'm going to focus on head and neck because I feel like it's the most practical and you don't really need ultrasound and it's pretty easy to do. Some contraindications to regional nerve blocks include allergies, if you have to go through infected tissues, if a patient has any bleeding disorders because of the risk of expanding hematomas that can cause ischemic nerve damage, and a relative contraindication is if they have any pre-existing neurological conditions, but just make sure if you do to document your pre and post neuro exam very well. Our main categories of agents fall into amides or esters, and both classes act to reversibly block sodium channels and inhibit the propagation of nerves. The main difference between the amides and the esters are how they're metabolized. So the amides, including bupivacaine and lidocaine, are metabolized by the liver. So be careful when you give large volume of anesthetic to your liver patients. As well, and then you have esters such as procaine, which was used back in the day, which are hydrolyzed by cholinesterase. For those people with true allergies to amides and esters, although most people are really allergic to the preservatives in the solutions, you can use diphenhydramine or benzyl alcohol for local infiltration. However, these agents are not well studied for regional nerve blocks and they're not recommended. So interns, what is the max dose of lidocaine without epinephrine? Call it out. Yeah, okay. So we'll just talk about a few agents that we use most commonly. So we have bupivacaine, which has the highest lipid solubility and protein binding, which is why it makes for a longer lasting agent. But at the same time, because of the high lipid solubility, it has a higher risk for systemic toxicities. The max dose of bupivacaine without epinephrine is 3 mg per kg, and when you add epi, you can go up to 5, for a total of 175 without and then 225 with epi. Lidocaine has a shorter onset of action, duration of action. It's about 30 minutes to about 60 minutes, and you can give, like we said, about 4 to 5 mg per kg without epinephrine and up to 7 with epi. Max dose of 300 without epi, 500 total. And if the patient has a true amide allergy, you can then consider giving procaine. And this has a very short duration of action, which is why it's fallen out of favor. But you can give larger doses, up to 7 mg per kg. All right, so back to our case. So now we have a laceration to the brow. What would you use to numb him up? I'm going to call on Dr. Kobner. E, good. All right, so in this case, you'd want to do a supraorbital / supratrochlear nerve block. And so these are the branches of the ophthalmic, the V1 distribution of your trigeminal nerve. As you can see in the green, the supraorbital nerve provides sensory innervation to the mid to lateral aspect of your forehead, going from your brow to your scalp. And the supratrochlear nerve innervates more medially from the glabella up to the scalp. And so the supraorbital nerve comes out of your supraorbital foramen, and how you identify that is have the patient look straight ahead, look at where the mid pupil is, and draw a straight vertical line. And you can also feel this on your own eyebrow. You should feel a little notch right there. So in order to do this block, you can put about 1 to 3 cc's over the notch, but I would not inject directly into it. And if this doesn't work, you can do a field block where you inject about 5 cc's going lateral to medial, and this should block both nerves. Make sure you apply some pressure at the brow to minimize the complications, including some hematoma, swelling of the eyelid, and let the patient know that they may develop periorbital ecchymosis, and it should go away, but just wear some sunglasses for the next couple days. Case 2, we have an 18-year-old male referred from jail for a laceration to the upper lip after the fall from bunk. What technique would you want to use? Dr. Ross. Infraorbital, yes. So your infraorbital nerve is a branch of your V2, the maxillary nerve, and it comes out of your infraorbital foramen. This This nerve innervates the sensation from the lower eyelids to your upper lip as well as the side of your nose, but does not hit the mucosa. The infraorbital foramen can be located by also extending that straight vertical line from your supraorbital foramen down the midline of your pupil and to a little notch over your maxilla right here. There are two ways that you can block this nerve. There's the external approach as well as the intraoral, which is a more preferred route. For the external approach, you found your landmark and you just want to inject a couple cc's next to it, but you want to avoid any vasoconstrictors, avoid the use of epi because of all the vasculature that runs next to it. If you happen to accidentally use epi and you get some blanching of the face, you can immediately put some warm compresses on, or you can also locally inject a little bit of phentolamine to reverse it. The intraoral method is more preferred because it's generally less painful, more successful, and it's longer acting. So your landmark is between the first and second premolar, and you want to inject the needle at the junction of the labial mucosa and the gingiva, directing your needle towards the infraorbital foramen at a depth about 2.5 centimeters. You want to inject about 2 to 3 cc's, but if this doesn't really work, then you can do a little field block where you go in a fan-like distribution and inject 5 cc's. Case 3, we have a 25-year-old female referred from jail after a laceration to the lower lip, crossing the vermilion border. She also grew a beard and got a tan. What technique would you use? Dr. Bench. Mental nerve, yeah. So your mental nerve is the end, it's the terminal branch of your IA, the inferior alveolar nerve, which comes off of your mandibular, the V3 distribution of your trigeminal. The mental nerve itself innervates the anterior lower lip as well as the chin, and this comes off of the mental foramen, and all your foramens are all in that line, in line with your direct pupil, and this is on your anterior chin, so you can palpate it on yourself as well. So once again, there's two approaches. There's the external approach, which is not as recommended as the intraoral approach, and so use the same landmarks between the first and second premolars and into the junction of the labial mucosa and the gingiva. Case 4, 30-year-old male split his own tongue and now he regrets it. What technique would you use? Dr. Darby. Well, you could do that, or you could also do a better block, which is the inferior alveolar nerve. So, as we discussed, the inferior alveolar nerve is a branch of your V3 nerve. So the IA nerve itself only innervates the lower lip, lower teeth, the lip, and the chin, but it runs right adjacent to your lingual nerve right here, which actually provides sensation to the anterior 2/3 of the tongue. So when you do an IA nerve block, you should also get the lingual nerve as well. So your landmark for this is your little pterygomandibular triangle, which is a little divot here, and medially it's bordered by your pterygomandibular raphe. So you see this is kind of where you're aiming for. And when you do this block, the angle is key. Make sure you're going at a 45-degree angle and have the barrel at the syringe at the contralateral first and second premolars. And if you feel like you're having a hard time achieving the angle, then you can bend the tip at 30 degrees. So we'll show a little video. So you can retract the gingiva, and you see the little divot there. Okay, that's it. All right. So some complications if you inject a little bit too posteriorly, so make sure you're hitting bone before you inject, because you can actually accidentally get the parotid gland, and that's where the facial nerve runs, so then the person will look like they have a Bell's palsy. And also, this sometimes can be an unsuccessful nerve block, so what then can you do? So this one is not as common. It's called a Gall-Gates block, and it innervates the same nerves. So you get your inferior alveolar, your lingual, as well as your buccal nerve, which supplies the cheek. You have the patient open fully because these nerves run near the condyle of your mandible. Once again, here's your anatomy. Okay. And so what you're aiming for is you want to aim for the condyle, so you want to hit the bone, but you want to direct it towards your ear in the intertracheal notch right here. And you want to inject behind the second or third molar, and you want to hit the condyle. That's what you're aiming for. And then there's your nerve block. Okay. So your Gauge block has been shown to have a lower rate of vascular aspiration when compared to the IA nerve block, but some complications include if you accidentally aim a little bit too medially, you can anesthetize the sympathetic plexus, so they'll get a little bit of a Horner syndrome. So litosis, meiosis, anhidrosis, right? And then now you have someone that got punched in the ear or fell off a bunk again, and they have an auricular hematoma. And so you can also then think about doing a diamond or an external ear block, so that, especially if you have an auricular hematoma, you want to prevent the further separation of the perichondrium from your cartilage. So you just do a diamond block where you inject at 12 o'clock and 6 o'clock below and above the pinna. And you want to inject anteriorly so that you get your auricular temporal nerve, and posteriorly so you hit your lesser and greater auricular nerves. All right, so it's 3 a.m., you've done like 5 lacs, and now you get a bolus of 4 new patients, and now you get this leg lac that's 20 centimeters, and it's so deep, but it's not deep enough to call a consultant, and so you look at the West track and you call over the med student.
Get over here!
30 minutes into it, while you're charting, you hear, "Doctor, the patient's seizing," and he has no prior history of any seizures. So you look and you see the med student, and next to the med student, you see all these bottles of empty lidocaine. So interns, what do we do? What's your algorithm? What's our mantra? IVO2 monitor. Okay. Next, go through your seizure algorithm, call for intralipid, and call for EKG. So what this patient is probably experiencing is local anesthetic systemic toxicity, which can affect your CNS, your cardiovascular, and your hematological systems. Usually, the effects that you experience are usually time and dose dependent, usually starting off with non-specific symptoms such as tongue numbness and some hallucinations. But as you have an increase in dose, you can then progress to seizures and then finally cardiac arrest. The only exception is bupivacaine, which often presents with cardiotoxicity or seizures as its first presenting symptom. So then, we talked about intralipid for a second. So intralipid has been shown to be pretty efficacious in anecdotal cases as well as in animal studies, but it still hasn't been really showed much in human studies. However, there's few side effects unless you dump a whole lot in, so it's still recommended to be given when you have anesthetic toxicities. The thought is that the highly lipophilic molecules are drawn into this new intravascular lipid compartment. And so per the American Society of Regional Anesthesia guidelines, they recommend starting off with a 1.5 cc's per kilo bolus over 1 minute. Then you can start a drip, which is 0.25 cc's per kilo per minute. If they're still persistently hypotensive or have evidence of cardiovascular collapse, you can repeat the bolus and then you can go up in your drip, but you don't want to give more than 10 cc's per kilo because then you run the risk of running into pulmonary toxicity, pancreatitis, and hyperlipidemia. All right, but when to initiate is the question. So there's no clear consensus. So the American Society says impending seizure, but I don't even know what that means. The Great Britain and the UK doctors say if they have any evidence of AMS, severe agitation or loss of consciousness, but for sure if they have seizures or any cardiovascular symptoms, you want to give it right away. So management of seizures. Like we said, intralipid, so that's already been established, but you also just treat it the same way. Benzos, barbs, get your glucose, your ISTAT, and if you decide to give propofol, just be very, very careful because if they have any cardiovascular compromise, that's something I would stay away from. And then you get the EKG. I'm gonna call him Dr. LeClaire. What do you see?
There's widening, it's fast, tall arc wave, and AVR.
Mm-hmm.
What else?
Yeah, that's it. So you have your dominant R wave and AVR, and you have your wide and QRS, right? So this is similar to a TCA toxicity because the mechanism is the same. Your sodium channel blockade. So in addition to calling for the intralipid, you can give sodium bicarb at 2 MEQs per kilos, and this is at any evidence of any EKG changes, any cardiovascular compromise. And if you happen to start your ACLS algorithm, there are just a couple tweaks. So you want to use amiodarone as your first-line antiarrhythmic. If you give epi, make sure you give it in a smaller dose. So instead of giving your 1 milligrams of epi, you can go down to 10 to 100 mics. Avoid vasopressin because of its for its arrhythmogenic properties. And for some reason, do not give beta blockers. So for some reason, if you think about it, do not give beta blockers or calcium channel blockers because you don't want to bottom the patient out in terms of their pressures. If you have ECMO at the facility, this is actually something to look into because otherwise you may be coding the patient for a very long time until the anesthetic runs out. Yeah.
Is intralipid on?
Yeah, intralipid is part of it. So, yeah, intralipid is part of any CV toxicity.
Does that lower your time that you need to code someone, or is it just you don't think about that?
So, I mean, I think the idea in dogs, there are studies that show they're coding dogs, and once they give the intralipid, then they achieve ROSC sooner, but it hasn't been shown in humans. So there hasn't been many studies done. So some people can get methemoglobinemia as well because of the oxidant properties of some of the anesthetics. So you then, take your iron from its ferrous form to the ferric form, and so you traditionally see some of the cyanosis as well as the chocolate brown blood. And your antidote is methylene blue, 1 to 2 mg per kg, but be careful in any G6PD patients because of the risk of hemolysis. And you can also consider high-dose vitamin C or ascorbic acid because of its antioxidant properties. All right, so now you're about to wrap up your shift, and then now someone's screaming in room 6, "Doctor, I have a headache, only that D drug works." And now you're just kind of like this at this point. But you do have to address his concerns because you're a caring doctor. He says he's allergic to Tylenol and ibuprofen and he also has a prolonged QT because his psych meds. So you don't want to give Compazine or Reglan. So what do you do next? Yep. So we've talked about nerve blocks in the setting of procedures, but there are many studies that have been shown to demonstrate the efficacy of these nerve blocks for the treatment of headaches. The greater and lesser occipital nerve blocks do provide cutaneous innervation to the scalp, as you can see here, which is really handy when you have extensive scalp repairs. But blocking the greater occipital nerve, which is a branch to the C2 nerve, has been found to be pretty effective in treating occipital neuralgias as well as cervicogenic headaches. And these are headaches which by definition are secondary to a process in your C-spine or the surrounding structures. In order to find the greater occipital nerve, palpate the occipital protuberance, which is located in your posterior scalp midline. And then you want to palpate about 2 to 3 centimeters laterally to it and 1 to 2 centimeters inferiorly to it. And you should feel your occipital artery. Once you find that, you can inject about a cc or 2 into the left and the right side of where you find the pulse. Okay. And in order to anesthetize your lesser occipital nerve, your landmark is the mastoid process, and your nerve runs right posteriorly to it. And you can use that as your landmark to anesthetize your lesser occipital nerve. If you can't find the pulse for any reason, what you can do is you can divide the line from here, from your occipital protuberance and your mastoid process into thirds and infiltrate the middle third with about 5 to 8 cc's, and that should actually block both nerves. So where's the evidence for this? So there was a journal, meta-analysis published in the Journal of Emergency Medicine in 2015 where they looked at a bunch of different types of studies for different types of headaches, and they basically graded the evidence. And what they showed that there was moderate evidence suggesting that these nerve blocks were pretty efficacious for treating cervicogenic as well as cluster headaches, but not so great for migraines or for chronic daily or for tension headaches. These studies also suggest that there may be some kind of connection between the greater occipital nerve and the trigeminal nerve, which is why these seem to be efficacious for cluster headaches. But then more recently, in November 2017, in the American Journal of Emergency Medicine, there was another meta-analysis where they looked at the greater occipital nerve block in the setting of migraine patients. And basically, the overall results were that it decreased the pain severity, the number of days that patients had headaches in a 4-week period, as well as the amount of medication consumed. However, there was no significant impact on the duration in terms of how long the headache actually lasted for the 4 weeks. Another nerve block for headaches that has been recently popping up has been the sphenopalatine ganglion block. And the sphenopalatine ganglion is located in the posterior middle turbinate right here. And so the mechanism is unclear, but the thought is that there's a blockade of the parasympathetic outflow, which is thought to be involved in headaches, as well as an alteration of the pain processing by modulating the sensory afferent fibers of the trigeminal nucleus. I would not use this in people with facial fractures, any coagulopathies, any bleeding. And this is a quick video from Alium. It's pretty straightforward. So you literally just dip a Q-tip in anesthetic. And once again, that's your sphenopalatine ganglion. that's it. All right, so it's pretty easy, right? So there's been some mixed evidence for this. There have been 2 double-blind placebo-controlled studies using bupivacaine versus normal saline. The first one was studied in the Journal of Headache, where they actually looked at people with a known diagnosis of chronic migraines, and they basically measured the pain scores before and after treatment, and they showed that this statistically significant difference in the people who had bupivacaine in the blue versus the saline. Yes.
You do this bilaterally or
Unilaterally, yeah. However, now in the emergency department, how does that apply? So then in the Annals of Emergency Medicine, they did the same thing, except all the patients were now patients who had frontal primary headaches, and they also then looked at the outcome of the pain score between the first 15 minutes, and there was no statistical difference. However, when they did a phone follow-up in the 24 hours afterwards, it seemed like the people with bupivacaine had a lower pain score than the people with the placebo. So there's still evidence. This is not, your first-line treatment. However, in a busy shift where you have, tons of patients that all need ultrasound-guided IVs, you can try attempting this and see how it works. Just a couple more tools in your toolbox. So that's the end of my talk. Here are my sources. Honestly, thank you to Dr. Garlick, Levine, Newton, and Yan. And I'll leave time for questions, but it's okay if you don't have any. All right.
All right. Thanks.